All right, good afternoon and welcome to today's solutions session hosted by ERS. My name is Bernie Hayaski. I'm with the Enterprise Planning Office, and with us today are representatives from Advanced Medical Pricing Solutions, also known as AMPS. Okay, glad to have them here to discuss their medical bill review services. Ground rules for today's solutions session. The presentation will last up to 45 minutes, followed by Q&A session from the staff that are in attendance today. The session is being recorded, so when speaking, please try to speak up so that we can capture the questions or the comments that you are making. With that, I will turn it over to the AMPS team for their presentation. Thanks, guys.
Let me borrow this for a second. Do that. Oh, heavy.
Thanks, Bernie. Good afternoon, everybody. My name is Mark Matsock, and I am the task leader for Advanced Medical Pricing Solution, also known as AMPS. And we are very excited to be here today to introduce our cost-saving methods that we feel very confident are changing the paradigm of healthcare and healthcare costs. So with that, I know we're on some time, and I will turn it over to our partners, John and Doug.
So just by way of introduction, John Powers, I'm Executive Vice President at AMPS. I've been in the healthcare cost management sector for about 25 years. I've been fortunate enough to conduct successful investigations in over 120 different countries, including Texas being one of those countries. Just something I'm really passionate about. And we're talking today about how we can help you with the broken healthcare system. We're not pointing any fingers at any of the carriers, but it is a broken system. And when we talk out there talking to states or other municipalities, it's why do you do this? Well, because we've always done it that way. So we're going to show you today some of the things you can do to have a direct and immediate impact on your plan dollars and put money back in members' pockets. With me is Doug Aldine, our corporate counsel. I'll let him introduce himself.
That's right. My name is Doug Aldine. I'm actually an Austin-based healthcare attorney. I've been in Austin now for 2.5 years, from Montana. And I do all of the work for AMPS, both in-house and across the country.
So from the legal perspective, I know that you guys will have some good legal questions. I brought my lifeline here right with me today. So with the agenda, we're going to level set on what that problem is, and that might be redundant to you all. We know we're preaching to the choir about some of it, but as we talk about how we solve the problem, I think it's important to define the problem and exactly what parts of the problem we're addressing. And we're going to talk about how we address it. The process issue in today's healthcare space is specifically in hospitals and facilities, and then we're going to talk about that AMP solution, how we solve that problem, how we save health plans like yours or ERS money and put money back in your trust as well as the plan participants or members. And then we're going to talk about potential roadblocks, a lot of the questions you might have. What could go wrong? Why isn't everybody doing this already? So we're going to spend some time on that. And throughout the segment, we know some of the questions you'll have, but we're excited to hear the questions you have at the end. And then finally, what could it mean for you? What could it mean for ERS in terms of financial impact? And we've taken a stab at that based on your spend over the last 3 years and our more than 122,000 claims that we've audited or reviewed this year, how that could transfer over into your medical spend. AMPS is a healthcare cost management company headquartered just outside of Atlanta, Georgia. We've been in business for 16 years. And I got on here, even though we're talking about medical bill review, some of our other solutions, which will kind of bleed over into today, but of course Texas is the birthplace of reference-based pricing or PPO replacement programs. That's something that we do a lot of. In fact, we have several Austin-based clients, and a lot of what we do is reference-based pricing. But the first step on reference-based pricing is cleaning that claim, making sure that all the charges are valid and medically necessary. We also have a program that we call Care Connects, which is like a concierge-based service where we help members make the best decision for themselves, including financial decisions. So, for example, if a member needed to have knee surgery and it would be at Memorial Hermann in Houston, maybe the plan out of pocket would be $2,500. Well, if we have a direct contract with a surgical center right down the road, it might be free for the member. So that's an emerging trend that I'm sure you're seeing today, both in the reference-based pricing, but in that concierge medicine to take care out of hospitals where it might make sense for the member. We are proud to say that we're a physician-led organization. When we're doing medical bill review, we're going to show you some examples on claims, mistakes that were made that only a board-certified specialist physician could find. You'd have to be a cardiologist to find this error. You couldn't do it from a desktop base or a piece of software. So we're proud to say we're a physician-led organization, but we're high-tech, and we're going to show you a sampling of that as well. Our largest client has 420,000 members, not employees, but members, and we work with several Fortune 500 countries or companies across the country, including a few of those in the state of Texas. This chart just depicts the waste in the system as reported by the Journal of American Medicine that recently said that there's about $930 billion in waste in the system. And what we did with this chart is really focus on where that AMP's impact would be on pricing failures, where there's some egregious charges. Maybe it's $500 for Tylenol, might have been a keystroke error, who knows what it was, but that would fall into that pricing failures. Or fraud and abuse. I prefer to call it waste, abuse, and fraud. Fraud's a term that is used probably too much. First 15 years of my career, I was a fraud investigator, and in order to prove fraud, you really have to prove intent. A lot of these are just mistakes. I don't think people intended to defraud the system. That does happen, but that's really a Department of Insurance issue. Of the claims we focus on, a lot is concentrated in hospital use, and this slide or graph just shows you that with all the claims we look at annually, we found if a plan has a medical spend of $100, about 49% of that usually happens in a hospital or a facility, and the other 51% would be primary care at a physician's office or a professional claim. You can think of the two different buckets. One might be billed on a HICFA or professional claim, and one might be billed on a uniform bill or a UB. So you got about a 50-50 spend in most health plans. From hospital and facility claims, which are the larger dollar claims, and then your professional claims, your regular doctor office visits. And if you look at large dollar claims, our sample set that we looked at last year, of the claims over $20,000, that equated to only 6% of all claims. But yet those 6% of all claims impacted at 62% of the planned spend. So it's kind of a Pareto principle, for familiar with that term, that law of the vital few. And you think about it, there's only a few claims that are really impacting your spend, and that's kind of a good way to think about. We're not too concerned about your child has a strep throat and you go to the doctor and they bill you $75 for that. We're concerned with those $200,000 claims, those $1 million claims. A lot of what we focus on is claims over $20,000. This chart came out of our database coming back from 2011 all the way up to the end of 2017, and it just shows you the great spike in hospital billing over the last 3 years. It kind of runs a lot in alignment with the Accountable Care Act, but you've also seen some hospital billing increase over the last couple of years. What do you attribute that to?
Yeah, well, basically the ACA has created perverse market incentives due to the MLR. And so it used to be where insurance companies were able to, negotiate with a hospital whatever that arm's length transaction would be. The ACA requires a spend of 80%. So in other words, insurance carriers have to spend 80% of the dollars they collect. 20% is kept for administrative expenses. And so what's happened in the marketplace as a result of that is you'd rather have 20% of a larger number, i.e. 100 billion, as opposed to 20% of 1 billion. So as a result, you see the spike in charges relative to costs in the marketplace. So if you're an insurance company, United, you're going to meet that spike there because 20% of 100 billion is better than 20% of 20 billion. But anyway.
So yeah, if you look at 2017 here, of course, the top line is billed charges. And does anybody pay billed charges?
No. Billed charges, even in Texas as an example, billed charges, it's a list price, it's a starting point, it's a rack rate. Even Texas, recently, as I think April, came out with a Supreme Court case, even though it was in the MBA arena, billed charges are not reasonable. And there's something underneath which hospitals accept, whatever that number may be, that is the number that creates a fair market value.
So the top line would be the billed charges. The purple line next is the PPO allowable charges. And so if the bill charges are 600% of Medicare and you've got a 50% PPO discount, you're coming in at around 300% of Medicare. We're going to show you some more granular numbers as we go along. But the next line is what AMPS resolves claims at, and then the bottom line would be what Medicare pays. And this graph just shows where our focus is. Our focus is the allowed amount. My definition for the allowed amount is bill charges minus PPO discount, allowed amount, what you would have paid, and then where we resolve claims at, claim dollars at, that difference or that delta is really where we play in. The next slide is we pulled some up to the minute data that was just released through Medicare about some 3 area hospitals, and you want to talk about these a little bit?
Sure. So CMS obviously has publicly available information, and if you look at these charts and you look at the information, you're going to look, and these are 3 hospitals, one in the Valley, one here in Austin, and then one in Houston. And if you look at their charges relative to their costs, I mean, you can run the numbers yourselves, but you're talking over a 5-year period, at least with the hospital in the Valley and in Austin, your charges relative to your costs have increased dramatically. And just to give you just a little bit of background, if you look at, in the Medicare world, there's a concept called turbocharging. And turbocharging is when a hospital increases its charges relative to its cost to access outlier payments. And there's a host of cases, and from 2009, say, through 2012, where hospitals in New York actually did this. They're fined, people go to prison, all the bad stuff. But the point being is, what happened in the Medicare world is exactly what's happening in the commercial market as we speak. So, and again, this is all information publicly available. It's the hospital's own information, so they report this information. But if you do the math, charges relative to costs, I mean, it's pretty apparent what's happening.
And that outlier provision, you all are likely familiar with it. We're seeing a ton of I'll refer to them as ASO or administrative-only providers, whether it's Blue Cross, United, Cigna, Aetna. I don't have a favorite. I kind of lump it all into one, ASO versus an independent TPA. And these outlier provisions that these hospitals sometimes game the numbers to, where they have a minimum payment provision where they might have a surgery that's billed at one bundled case rate, unless their billed charges, unless their charges eclipse that minimum payment provision, then it reverts to a percentage off of billed charges. So a lot of what we do is on these outlier claims, these high dollar claims where you thought you might have been getting one bundled rate for a service, and the hospital had, for whatever reason, the charges went up and it kicked into a percentage off of billed charges, and we're seeing that a tremendous occurrence of that within Texas, within the carrier-based PPO models. This chart is local, Austin-based hospital, and we thought that was important because wherever we are in the state of Texas, they might say, well, that happens over there. It doesn't happen right here. And we realize you have members across the state of Texas, but I found this one particularly intriguing, being local.
Yeah, and just digressing, I mean, so between Florida and Texas, I mean, it's neck and neck, and I know it's a dubious honor, but hospitals in Florida, hospitals in Texas lead the nation in terms of charges relative to costs. I think Florida actually is number 1, but Texas is not a far distant second.
And then the third hospital is Houston Area Hospital, which was an independent hospital until recently and got acquired by a larger hospital system without the state of Texas. So you guys could probably figure out who is who. And again, it's a broken system, and we know that some are profit, some are nonprofit. Our job isn't to point the finger. Our job is to correct the claims and make sure that you're only paying on a valid and clean claim. So we talked earlier about it really being a process problem, and this is something that when we're out talking to folks, there's some assumptions that they make because the way they manage their business or their plan or their system, medical claims really aren't processed that way. So, most folks are aware of that universal bill, but to shrink it down to lowest common denominator, that's just a summary of the charges. And in our experience in the last 16 years, 98% of all claims are paid off of this summary of charges. I liken it to American Express bill, where I just pay my American Express bill off the cover sheet, just the summary. It says, oh, $5,000, well, it's Christmas, it sounds about right. I never pay off of that. I look at those detailed itemized charges and say, wait a minute, I didn't go to Starbucks. 98% of all claims in Texas are paid off of the UB, or the summary of charges. Then there's the itemized bill, which has that line item level charges. That's what we do. We get the itemized bill and we do a forensic review line by line. We look at every single line item. And some of these complex cases are 110 pages of itemized bill. So our report are 120 pages long. So this is the most fundamental part of the problem, is that claims are paid off of the universal bill and just the summary of the charges. And why is that, Doug?
Well, I mean, they're, in terms of the IB, most people don't, I mean, most organizations are not requesting the IB, I think, is ultimately what it comes down to.
Well, and a lot of the PPOs have negotiated deeper discounts to pay the claim faster. Is there prompt payment concerns?
Well, there is, but ultimately, it's got to be a clean claim. I mean, so, if you look at your PPO contract, I mean, it's going to say, the prompt pay as long as it's a clean claim. Well, in our view, if there's errors or it's not covered for whatever reason, it's not a clean claim until it's at least examined and looked at.
And your prompt pay laws are not the Texas prompt pay laws being self-funded, so to speak. I'm sure they're nested within your PPO agreement. And then finally, the last piece is less than 1% of the time our team might request, though, just detailed medical records. Most of the time, the itemized bill is enough, but less than 1% of the time, we really need to dig into what happens. That might be the notes that the doctor transcribed right as they were looking at the patient, those detailed medical records. But the process problem, and here's a sample UB, that is from a Texas-based hospital. I think this tells the story more than anything. I don't know if you guys can see that okay, but halfway up here, you got 322 units of laboratory billed for $157,000. And if this doesn't call attention to the problem, to know that 98% of all claims are paid off of a UB like this, a UB04 like this, and Doug mentioned the prompt payment requirements in your PPO contract would be governed by that clean claim. We might agree or disagree on many things, but the one thing I will never agree with is you can't pay a claim off of a UB. What are 322 units of laboratory, and why is it worth $157,000? And most folks would say, but we got a 50% discount. It's okay. But what is this? I don't know what it is. And we think that we help fulfill that responsibility to make sure only valid claims are clean claims, because on the itemized bill, it clearly states what that is. And that's part of the secret sauce, is we get the itemized bill every single time. And one of the claims we make is we have more detailed medical bill information than anybody in the state of Texas. That's a big statement, because we're not a huge company, but the fact that we got the itemized bills on 122,000 claims last year, it's pretty easy to make that claim. So defining the problem, how claims are paid, and how there might be some PPO restrictions to what you can and cannot do, is really what we talked about. Now we're really going to focus on our solution, how we solve this problem, how we dig into those detailed itemized bills with our board-certified specialist physicians, and what we find. It shows here that we find errors on 10 out of 10 claims. It might be a $2 error, it might be a $200,000 error, but virtually every single hospital bill over $20,000 has an error on it. One of the things that I hear is, our ASO provider or our TPA is already doing this. It's in our contract. They said they're going to make sure it's a clean claim, or they're going to audit the claim for us. So we've looked at it over the past years and found that, yeah, there's companies out there that do claims audits. But that's different than what we do, and I just put a little table to kind of dissect the differences. And on a claim audit, that would be post-pay or paid claims where the carrier might take, or the administrative services provider might take a small sampling. Maybe they'll take 300 claims from last year, and they'd audit those post-pay, and they'd look at that UB, that claim summary, and they'd see if there were duplicate claims from the same date of service. They'd see if maybe the plan document was enforced. Maybe your plan covers 5 chiropractic adjustments a year. They might find 6. So those are some of the things, those are rules-based. And ours is really a detailed medical bill review to make sure that it was the right care at the right time and finally for the right price. So different from the claim audit is ours is prepayment before the claim is paid as a cost avoidance thing. We look at all hospital and facility claims, not just a small sampling. We get that itemized bill, and ours is inferential. So we're looking for the national billing and coding standards on hospital and facility claims to make sure those are followed. We're looking for clinical errors. We're going to give you some examples of that. The other unique thing we do is we benchmark it for reasonableness. So for example, I know you guys have access to some PPO agreements, but also have some of your own contracts. So a rhetorical question that I ask everybody is, hey, what are the value of your contract? So if you have an average 50% discount, off of what number? What's the value of that? Nothing else that you buy in your own personal life is what is that really worth? So what we do on every single claim, we benchmark it to Medicare. So we might say it was billed at down in the valley 1,100% of Medicare, and you got a 60% discount. Anything else? 60% discount? I think that's a great deal. But you're paying 700% of Medicare or 300% of Medicare. Is that fair market value? So on top of cleaning the claim, we also help you determine the value of your agreements because, as I mentioned, we also do reference-based pricing. We know what others are paying to access those same facilities. The AMPS process, and you could probably figure this out, but it starts when whoever is processing your claim today gets to step 7 maybe. They're right at that point where they're about to press print and issue a virtual check. They've exhausted all of their resources to make sure that it's a reimbursable amount. So rather than sending that payment off, they pen that claim, they send us that UB and the IB. So if you're worried about, hey, what if you're finding things that we would have found? We're the last step before payment, so we know that we're not double counting errors. So whatever your team may have found or your other vendors may have found, we're last, and then they get sent to us, and we take that itemized bill, we digitize it, and we put it in our proprietary technology, which really normalizes that bill. And you got 2 different hospitals here, 5 minutes from each other. I looked at them yesterday. They bill for a 2-inch Johnson & Johnson Band-Aid, slightly different. So it's like decoding Mandarin in one and Spanish in another. It's very difficult to compare bills side by side. So the first thing that we do with all the millions of bills we have in our system is normalize them so we know we're comparing apples and apples. And then we go through, our technology finds those aberrant billing patterns and those outliers and tells our board-certified physicians where to look. Here's a problem here, here's a problem here, and then each one, there's a manual process. The things we're finding are things that computers can't find. And really part of that secret sauce is that board-certified specialist medical director review. It's really a peer review. Our team of physicians have been practicing. They're orthopedic surgeons, so they've done knee replacement surgeries. They got cardiologists that have done LVAD implementation or implants, so they know that you only need 2 leads. So if they bill for 4, there must be a reason there. So that peer review level where they can say, I've done that surgery before, and this is not the standard of care. This is not following protocols or evidence-based medicine. So there's a technology piece, but also a physician piece, and the physician piece is very important. Some of the skills that our team has, and you think about like oncology claims. We see a disparate number of chemotherapy regimens for all different types of cancers, but we make sure that they're following evidence-based medicine. For oncology, for example, you hear someone, we tried this, and then we tried this, and no, you can't do that with oncology claims. The best chance to cure cancer is the first time, so we're making sure that they're billing for things that are in compliance with NCCN standards, for example, to make sure that these are following evidence-based medicine. So they do the line item level review, and they find numerous things. They find things. This is not code editing, which I know you guys already do. The code editing would be more rules-based type of edits. They might be modifiers or things that are mainly done on professional claims. Our team looks at these facility claims, and they find things. We've got some examples we're going to show you, but every single week we find toothbrushes. Now, they're not always $1,000, but they're a lot of times coded as an oral cleansing device. In fact, we were in Time Magazine for this a couple years, the cure for the $1,000 toothbrush, or a mucus recovery system at $75. So this creative billing keeps happening, and it's not everywhere, but it happens all the time. This chart is one we're pretty proud of. It just shows all the claims that we did medical bill review on in the state of Texas last year, 122,000 claims, and on average, we found an additional savings of 10% on those claims. After the claims payer, a TPA, ASO, or whoever said, we're done, we're ready to press print and reimburse this, we were able to find 10% additional savings on there. And interestingly enough, although, as Doug mentioned, the Valley, it can eclipse 1,000% of Medicare. Across all the claims we looked at, the average gross billed charges as a percentage of Medicare was 560%. And then after the PPO discount, it was coming in at about 305%. Some facilities are lower, some are higher, but these are a lot of these PPO contracts. When you wonder what the value is or where you're at, if you don't know, I'm guessing you're somewhere between 260% of Medicare and 300% of Medicare after that award-winning 50% discount. You see here the average rate of appeals. What that is when we make a recommendation, you pay with our recommendation. Sometimes the facility doesn't agree with that. Now, our solution is not to save money. That's a byproduct of it. Our solution is to make sure that the claim is accurate and clean, and we pay it that way. We're not trying to turn the screws to the hospital, so they can appeal our findings, and if they have additional information that changes how we reviewed the claim, we'll re-review it. An example might be if it's an obese individual that was having an appendectomy, there might be some complications, and they had to bill for some things that wouldn't have been the standard of care during a normal appendectomy, but we had no way of knowing on the medical bill why those complications occurred. So if you see here 96, or there's 5% appeal rate, 5% of the time they come back and say, hey, wait a minute, we don't agree with your findings. Great, tell us why we missed this. And so we were able to retain 96% of our original financial savings after we corrected the claim based on their additional information. Just some quick claim examples. They go from small dollars on duplicate charges and some unbundling on this one. We found an additional 5.8%, so $6,000. That's great. $6,000 is a lot of money, but there's some higher dollar ones. This one is a 29% savings. This was a newborn that was in the NICU for being underweight and having some respiratory problems, but after the halfway through the 8-day hospital stay, that newborn was stabilized and didn't need level 4 NICU care. Clinically, they only needed level 3 NICU care. So after reviewing the claim, we said, hey, you upcoded the NICU care, and we were able to downcode that and save an additional 29% in the claim. So only a neonatologist could look at that claim and say, hey, they didn't need that level of care. So this is where that secret sauce of that peer review comes in and validates those charges. As we say, trust but verify. We're there just to verify, did this actually happen and was it necessary? This is just a standard data entry error. It's important to realize that, I forgot to mention, all of these claims are claims that we worked on in the last 30 days, and after they triaged them, they ordered an adenosine test, which is a drug-induced stress test. So they ordered the test. As they continued to monitor his progress, as they talked to him, they decided to do a gallbladder scan. And after doing the gallbladder scan, they were able to determine that the cause of the chest pains was actually calcium deposits in his bile ducts. And they said, oh, this isn't a heart issue. This is calcium deposits in his bile ducts. So they never administered that adenosine test, which is an over $100,000 drug-induced stress test. It was already ordered. Somebody forgot to remove it. You would have never caught that on the UB. Our cardiologist looked at it and said, wait a minute, I don't think this ever occurred. We found out it didn't occur and saved $133,000 on this claim. So it's that line item level of detail that you can't see on the UB. As far as what we could save, we looked at your claim spend over the past couple of years, specifically 2017, and made some educated guesses based on what we would think your breakdown would be on in and out of network, hospital and facility claims versus physician claims, and we went through, your annual reports, and if you had average utilization based on the number of members you have across the state of Texas, we think the savings we could deliver to ERS is in excess of $100 million or $113 million, and that's a huge number. And like, well, how did you get this pie in the sky number? We're going to show you here in a second, but we had to say, hey, what could this mean to you? And we know that based on what we've read and our experience with other large plans in the state of Texas, that line item level medical bill review is something that typically isn't done. I promised we'd talk about potential roadblocks, or why isn't everybody doing this, and if you walk through a claim, like any of those claims with the $5,000 savings or the $30,000 savings, if the hospital gets a check in for less than they expect, there is a chance that they could balance bill a member. Does that happen?
Not with frequency. I mean, it does happen, but in many cases, I mean, they take the check and it just moves on. But it does happen, but just not with a high percentage.
And what happens there, we have proactive member advocates on staff, because when you look at it, like, this isn't about shifting things to members. Those errors aren't reimbursable under the plan. I haven't read your plan document, but I can't imagine that it says you can pay for errors. So when the member does get a balanced bill, they either work through you or come directly to us, and we advocate with our legal team on behalf of them with the hospital and say, hey, you can't bill this way, and call their attention to it. And most of the time it goes away right then and there, because these are black and white national billing standards. These aren't gray areas. Hey, our opinion is this. These are black and white. And one of the benefits too, when we've had members, a very small percentage of time that a member gets a balanced bill, when we talk to the member and say, hey, we're disputing the $400 warming blanket that they charged you after surgery, and the member says, hey, wait a minute, I had to pay 20% of that. So we feel that there's this reduced financial responsibility. No one likes a bill, and the member's not going to have to pay that, but when they understand why, hey, just pay this. But when they understand, a lot of your plans have a 20% member responsibility, when it's 20% of their money, they're more inclined to say, hey, right is right and wrong wrong. Hospital facility pushback, Doug. What happens when the hospital's expecting a check for $100,000 and they get $50,000?
Well, I mean, there's definitely there can be pushback, but it's like anything else. It's always a negotiation. So, I mean, it's kind of the Wild West out there in healthcare, but there definitely there can be pushback.
So Doug deals with hospitals every single day. He's dealing with their revenue cycle management department or their patient responsibility department. And do they ever say, you can't correct that error?
No, absolutely never. And I've been a lawyer for 26 years. I've been in healthcare for 21. Never, not once.
What are the type of things they typically say when they're disputing
Can
a
you
charge?
pay more? That's it.
Yeah. And really what it comes down to, is it reimbursable under the plan? When they accepted the member, they accepted that assignment of benefits, they accepted what the plan pays. And no plan in America pays for the types of errors that we've shown you today. Some of the other errors that we're seeing with frequency right now are, and I called our chief medical director this morning. I said, what are you seeing specifically in the Austin, Texas area? And he said, well, in Austin, more than anywhere else in Texas, I'm seeing, very simple example is hospital bills for a chest x-ray. Well, there's two subcomponents of that chest x-ray. There's the actual x-ray tech to take that x-ray, and then there's the radiologist to read that x-ray. So it's supposed to be broken down, and just use round numbers. Maybe it's $75 to take the x-ray and $25 to read it. But what we're seeing is they're billing for that one code for the hospital chest x-ray, and later we get a bill from the radiologist for the fee to read that x-ray. So we're seeing that a lot in the Austin area, and we flag the facilities and know that if they bill for a chest x-ray, our system looks for, are they billing for a separate reading of that x-ray. So that's one that we're seeing a lot here locally. And then another one that is just flat out egregious billing, a claim that we in fact saw today from an Austin area hospital was they billed for $1,200 for the IV to put the IV in. They billed for the room and board. They billed for the nurse's time to put that IV in. They billed for the saline drip, and then they billed $2,100 to administer a high-cost drug. All they did is squirt it in the bag and it dripped into the body. So that's an egregious charge that we would challenge and say, hey, you billed for all these other things, that's integral to the care. You can't bill for that separate item there.
Exactly.
How about one of the things that some folks come up with is you signed up for, maybe not you, but a plan signed up to access a PPO agreement to get access to these 50% discounts. And sometimes there's a perception that you've given up your right to audit. So you're going to get the 50% discount on average, but you've got to pay that claim within 3 days. So in the past, people have had a perception that they waived their right to audit.
No, and I don't think so, because I think that ultimately, I don't think anybody could have contemplated in today's environment that charges would be increasing at such a rapid rate relative to their costs. And so, my thought is, it just, there wasn't, an arm's length transaction at the time, just because the contract, that times have changed, and right, wrong, or indifferent. There's just no way anybody could have contemplated at the rate that prices are increasing.
So your right to audit, certainly that could be a discussion to have. But it's amazing, when you think about 96% of the claims that we audit, and they short pay, or the hospital's receiving less than they anticipated, they don't say anything. To me, that's mind-numbing, that we don't call up and say, hey, we found some mistakes, is it okay if we pay you less? We followed the plan only pays this, and so 96% of the time, they accept the payment and move on, so they know that they were opportunistic, and they'd hoped to get it, but they didn't get it, it wasn't worth fighting. So to me, the fact that 96% of the time, they don't challenge it. I know 100% of the time, if we all went out to lunch and I decided to correct the bill and making a 50% adjustment on a lunch bill, we wouldn't get to the car before the sheriff came and arrested me, right? So you just look at the operational inefficiencies in hospitals today.
And even the client that we have that actually we work with to sanitize a bill before it even goes out.
The other question I have is shared fiduciary responsibility, not to dive deep into the fiduciary aspect of it, but I always wonder, in your ASO agreement, most ASO agreements, the carrier or the administrative services, whether it's Blue Cross, United, Cigna, Aetna, they volunteer that we will clean the claim for you. You don't need to use an outside service like AMPS. So when we see that, we know that, one, they're not doing it because they're not getting itemized bills. Two, you don't get a report that says, we looked at the detailed medical records and this is what we saved. So I wonder, do they share your fiduciary responsibility? And I always suggest that you ask them, hey, do you share a fiduciary responsibility to make sure that the plan assets are spent wisely? And when you ask that, they just don't say no. They say heck no, because they don't want the risk that goes along with that. When there are issues, we've built a defense plan to deal with it, all the way from the member advocates, all the way through the litigation specialist or provider relations, a full team of people. If there is an issue, we don't hide from it, we deal with it right away.
That's exactly right.
We promised a little bit of a look-see into our technology, and we looked at your mission statement about using analytics to achieve transparency in an opaque world and maintain trust. So just a few screenshots of our technology and the tools we have that our clients can look into real time and see what we've saved, where claims are, how much we've saved them on each individual claim, how much we've saved at hospital A versus hospital B, but real-time reporting and analytics to know what we expect on your additional claim spend, performance, review, or turnaround time. That's a question you might have. The vast majority of our claims are completed within 5 days, and Doug talked about most prompt payment requirements are off of a clean claim, so we're finding error on 10 out of 10 claims, enough to pen that claim for 5 days to allow you the ability to validate those charges to make sure that only clean claims are paid. So talking about, proof, how we could get proof of concept, we threw a big dollar figure out there, what we believe we can save you. How can we validate that or make it real for you? So our suggestion as a set of next steps would be, give us your 10 largest claims from the past year. and let us audit those claims. We'll redact them, or you'll redact them, but we'll execute a non-disclosure agreement and a BAA. But if you take the member's name and any other identifiers off, it'll be void of PHI. We'll come back to you within 14 days with our audit findings and show you what you shouldn't have paid on those 10 claims. And those medical bill review findings will come after we've had the UB, the IB, or the itemized bill, and the EOB, so we can see what was paid. And I promise you one thing, if you ask for the itemized bill on your 10 largest claims, they're probably not going to have them on 9 out of 10. I spoke to Blue Cross yesterday on a similar situation. They said, we wouldn't even know where to get the itemized bill, or we can't get the itemized bill. And yes, you can get the itemized bill. You don't have to pay a claim until you get the itemized bill. There's no way to verify that. So that's kind of our proof of concept that we typically do. 10 claims is a good start. If you want to go higher than that, we'd go higher than that, but we'll give you back your claims, what you already paid, and what our board-certified team of physicians would find. And then the why AMPS, looking at your mission and vision statement, we believe we can significantly reduce the medical spend, and we align with your values that we're saving not only the plan, but we're saving the members money. It's a sustainable health plan because it's closer to fair market value. We promote consumerism because they have an ability to see what's going on with their claims and enhance performance and elimination of that opacity. You'll know once and for all what a 50% discount means. So how about timing, Doug? What in today's climate in the state of Texas, how do you feel about the timing to undertake an initiative like this?
Well, I mean, the timing of all of this, I mean, you look at the USA Today, I mean, they're talking about hospital horrors and all the different things that happen with bills. The legislature's in session. I mean, it literally is on the tip of everybody's tongue. I mean, I do a lot of this, not only in Texas, but across the country, and it is absolutely, I mean, the timing of all of this is impeccable.
So
Take a look at under the hood.
Sure,
Yeah.
sure. Before we open up for questions, the last suggestion I'd throw out to you is ask your claims administrator 3 fundamental questions. One is, don't just tell me you're auditing claims, as it says in the ASO agreement, or you're doing medical bill review. Prove it to me. The federal government finds errors on 6 out of 10 Medicare claims. Those are the same hospitals that your members are going to. If you're not finding errors on 6 out of 10 claims, something's wrong. So ask and make them prove it to you. What gets measured gets managed, obviously. 2, hey, I know we're getting a 50% discount on our claims with your PPO or your direct contracts. What does that equate to? Benchmark that for me as a percent of Medicare. And it's funny when you ask them that. Medicare is the single largest payer in this country. Every single hospital knows how to bill a claim to Medicare. But when you ask them, hey, we got a 50% discount, equate that to a percentage of Medicare, they say, well, we can't tell you. That's proprietary. Proprietary about what? So 1, show me that you're finding errors. What percent? 2, what are we paying as a percentage of Medicare? And 3, ASO provider, do you share fiduciary responsibility with me like they purport to do in their ASO agreement? I contend that if you're relying on your ASO provider to clean your claims, it's like the fox is watching the hen house, right, Doug?
That's correct.
Bernie, how about some questions?
Yeah, that's about all the time that we have for the presentation. Thank you. We're going to open it up to staff here in attendance for questions. Be sure to speak up so that we can capture the questions and comments on the recording. Thank you.
Who's first?
How do you get compensated for your services? Is it on a contingency basis or hourly?
So a couple different models. Could be contingency. It could be a PM. We get asked a lot of times to have different pricing models. 98% of all our clients want that contingency-based reimbursement structure where we only get paid if you realize savings. And realize savings, if you remember my earlier example, we had a claim, we made a recommendation, there were some complications. Say we recommended a $20,000 reimbursement on a claim, but after the hospital substantiated those charges, maybe we would change it to a $30,000. Our fees adjust, it's only on savings realized. So 96% of our clients get a percentage of savings. A couple do a PEPM, but most vote for that contingency-based where you know it's a creative savings after you've done everything you could do to the claim.
I'm not trying to piggyback off that question, I'm not trying to pin you down on a hard dollar, but roughly just give us a flavor for the percentage that you guys would take as a total of that savings.
Generally, it's about 25%, and I don't know if you have stop loss, but if you do have stop loss, it's whoever saves the money. So we charge 25% of savings on creative savings and realized savings, and then if you had stop loss, they would pay for the savings that they realized. Good question.
So when you look at your, comparing how much plan could save, I assume I'm just assuming this, I assume you're going to assume it's a reference-based or percentage of Medicare savings amount because you won't have access to our contractual arrangements, right?
So we made estimated guesses on the savings weren't a reference-based thing. That was based on the contracts we know, both with carriers and PPOs in the area, on that 10% air rate, that we find 10% air rate. So if you have contractual, I know you have contractual agreements with various hospitals, we believe we're going to save you 10% above save you an additional 10% on those claims.
But you won't have our contractual arrangements, so you're going by what you think.
So for example, if you had a $100,000 claim and maybe you had a contractual agreement that had a 50% discount, or maybe it was a DRG, we would see the billed charges, we would see the allowed charges, because remember, the claim has been adjudicated, it's right before paid, so we would have some privity into not the contractual terms, but we'd know this $100,000 claim was going to be paid at $50,000. So we find some things that shouldn't have been billed or shouldn't have been allowed, we might take that claim down to $40,000. So we saved an additional 10%, and it would be 25% off of that.
Correct.
So along that same line, you look at detail from a user, in other words, you get to the detail billing.
We get to the itemized bill.
Do you ever request medical records?
It's about 1% of the time where the physician will say, I can't tell enough from this UB and IB, I need those detailed medical
But
records.
you don't start there.
We don't start there. It's about 1% of the time. It's rare. A lot of them are neonatal claims or hemophiliac claims, or these high $2 million, $25 million claims where we're getting those detailed medical records. If we need them, we can substantiate, we can articulate why we need those, and you can still be under those prompt pay requirements based on the fact that we can't validate if it's a clean claim.
That's correct.
And I thought I heard you say that earlier, and I could have misheard this, but you were referencing an ASC near Memorial Hermann in Houston. And I thought you said you checked your own direct contract. Do you have your own network of direct contracts?
We have direct contracts. For example, we have an Austin-based employer that has probably 15,000 employees in and around the state of Texas, which has allowed us to negotiate direct contracts. Not part of the medical bill review program, but those are folks that have gone without. Think of medical bill review as a PPO enhancement. For all practical purposes, you have a PPO arrangements with a carrier or your own agreements. That's another program we have, the reference-based, which would be PPO replacement, where there is no PPO agreements, where we've gone out and negotiated direct agreements with hospital systems and surgical centers within the state of Texas.
Are they primarily stop loss or out-of-network types of?
No, they're direct contracts. We've got some major hospital systems for some large Texas employers that we've gone to them and said, hey, XYZ hospital system, this group of firefighters, 4,000 firefighters, is not going forward with a PPO. There's 2 hospital systems in town. If you want the business, give us your best rate and let's get a contract. So the world is moving towards an arrangement where we eliminate that layer of opacity, which we call a PPO. So it started in Texas 9 years ago with Bill Miller Barbecue. You guys have led the charge with it, and it's finally getting around to entities saying, hey, we don't want a 50% discount off of a random number. So yeah, the reference-based or those surgical center contracts are ones we hold, but separate from the medical bill review program.
You reference a lot this percent of bill charges off of a random number, and I agree, we see the bill charges kind of meaningless, but we know that, through Blue Cross, a lot of their contracts with hospitals are not a percent of charges, right? They're on another basis, DRG per diem or something.
Sure.
I mean, your methodology is agnostic to the reimbursement agreement, right?
Exactly.
It doesn't-
Yeah, yeah. And, you know, DRG agreements or case rates or bundled arrangements are inherently a little bit better than the discount off of bill charges, but you still need to validate that DRG. Was there an extra day or two in the stay, or there's still about the same number of errors? We're looking for the right care, right time, right price. And we don't care what they build or how they build it.
That was my question as well. I think we do a very good job here. We have the aggressive contracting, we have a custom contract, we're not using a PPO contract. And so, very aggressive pricing, but we talked a lot about that, but you also are looking for the errors and other things that would,
Yeah.
that would be.
Yeah.
I mean, with that contract, we could come back and just tell you, all we're gonna do is validate that you do have the best contract and it was paid, and let's put it right under that situation. So we're always trying to make sure that whether you've already got the contract and are getting the best deal, or we're gonna bring it based on some of the information we can find that shouldn't be there, you know, that's the bottom line.
Yeah. And I do think that the TPA is a fiduciary, is a plan as well. So that is also written into our existing contract.
That just amplifies their responsibility and gives them some additional risk if they miss errors, or if they are not auditing claims, if they didn't they only looked at the UB and not the itemized bill.
So I had a note, so you said that you do yours off the itemized bill, but the TPA often doesn't have the itemized bill, but you go to the TPA and have the TPA request the itemized bill. So how long does that process take?
Most of the time, about 3 to 5 days. They can either do it directly themselves or use a third-party service to do it. So it adds another 3 to 5 days, and then we're 3 to 5 days once we get it. But it's amazing to me the claims that no one got the itemized bill on.
Have they made some business justification that, you know, the summaries are correct in 90% of the time, and so we don't need to do the extra work through the itemized bill? Is that what's happened?
You know, a lot of TPAs are so reliant on those PPO agreements that they don't want to buck it. They don't want to buck the system. They don't want to torque off Aetna, because if they do, we could lose access to them. And that's why I'm so passionate about, are they a fiduciary? Are they spending your money like it's their own? And you know, back in the day, we just didn't ever issue a check. Sometimes they call a hospital and say, we need the itemized bill. We can't give you that. We hear that once a week. We can't give it. All right, then you don't get paid. It's not a clean claim. Sometimes we never hear from them again. A lot of those were, probably 5-6 years ago, we saw a lot of manipulation under anesthesia, $17,000 chiropractic bills, where we said, we need the itemized bill, and they never sent it. We never heard from them again because they knew that they got caught.
You said in the beginning that you have your largest group has 420,000 members, meaning lives. How many employees does that group have?
170,000.
So do you have, how many groups do you have in that range, like 100,000 or up to?
100,000, you know, I'd have to run some numbers to see it. I know that our smallest client's 57 lives, so I know that it's all over the road. I could run some numbers and get back to you to give you an honest, accurate answer, especially since we're being recorded. I don't want to miss. I'd have to run it just to see exactly. You want Texas-based or across the country?
Well, just anybody with 100,000
Yeah.
lives or more.
Yeah, I'd say probably 15 from a
That's
medical.
the lives, what about employees?
No, I'd say 15 with employees above that number. The one thing I do know, and the reason why I referenced 57 lives, that claim for that NICU unit claim, they had 57 employees on their plan. So whether they had 57 or 570,000, a claim is a claim is a claim, and the hospital doesn't know who they're billing for. They might, but I don't think they do. So at its most fundamental level, we're concerned with one claim and how we can protect this member and this plan.
So of those 15 employers, and I know this is just, we're not holding you to, details, but of those 100,000 employers, do you know about how many of them are public versus private, and for private, ERISA versus non-ERISA?
I'd guess that probably 70% are private ERISA based, and the public ones, I know a couple public entities we have some private employers, like one group has some janitors on it, so they're subject to ERISA and not. That'd probably be more of a legal question for Doug, but it's sometimes a mix.
Yep.
Thank you.
He usually hits me when I start answering legal questions.
That's okay.
We got a few more minutes for any questions.
Yeah, so you're only doing this process, just to clarify, on a small percentage of claims, right? Because you're just targeting hospital claims that hit certain thresholds. I mean, is it just every hospital claim that's over $20,000?
That depends upon you. There's different thresholds. We've got some clients that were only doing their dialysis claims. We're saving 92% off billed charges on dialysis claims. We've got some customers who say every single hospital or facility claims. So an MRI we would get. So you determine, I think the average is hospital out-of-network claims at $0, whether a hospital or a physician claim. And then in-network claims, sometimes it's 5, sometimes it's 20, but you decide, and you get, with our management dashboard, you get back every month, and you can determine, doesn't make sense to do claims over 5,000. Our most successful clients have us audit every single hospital claim, but some people walk before they run. But you pick your own thresholds. And you might say, hey, we've got a direct contract with this facility, we don't want to audit their claims. We have several hospital systems as clients, where we audit their claims and we also, the domestic claims, but we also audit the non-domestic claims.
But you're doing all your work post-adjudication, right?
Post-adjudication, prepayment. Some folks do it post-payment. I'm just not a big fan of that, because once you can't put the toothpaste back in the tube. You're big enough where you might be able to go back and say, hey, we want this money back. Most employers don't have that hammer to go back and get it. We just believe the best time to get it is prepayment. That's why there's no argument. And really the goal is to keep the money in the system for the members.
We got time for one more question.
Do you work with, obviously you're sort of interfering in the payment process between the PPO, TPA, and the provider? I mean, are you getting any sort of like contractual issues where either the TPA, I mean, are you working with any major TPAs, and is there any like sort of contract issues where either party feels like you're not, you're sort of interfering with the contractual process and the payment process between the two parties?
I'm not aware of any, but I mean, I would defer to John.
Well, I know that there's a TPA here in Austin that uses the Aetna network. They don't want to audit any claim. They are reliant on Aetna. And then we've got another TPA in San Antonio that says, hey, listen, we have a fiduciary responsibility to protect plan assets. So, the contractual issues, I don't believe there's any contractual issue that would stand up in or out of a court of law that says you are prohibited from correcting an error on a claim.
And you are working with some of the major TPAs directly, like Aetna or Blue Cross, United, you have plans?
Yeah, so we would
with
call
them?
those administrative services only. We don't work with them. They're required to work with us, and they do it kicking and screaming. We had a 12,000 life sporting good company recently, and they told Blue Cross Blue Shield of Pennsylvania, you're going to work with AMPS. And they said, well, we already do that. You don't need to do that. And then they said, well, show us what you're doing. Right care, right time, right price. We don't care if it's Blue, United, Cigna, Aetna, Humana, whoever.
Oh, absolutely.
Okay, well, that's all the time that we have for today's solution session. I want to thank the team from AMPS for being here today. I also want to thank the staff for their attendance as well. We'll see you down the road. Take care. Thanks.